Welcome to The Explainer. Today, we're diving deep into the fascinating pathology of valvular heart diseases. We're going to uncover exactly how these vital, life-sustaining structures inside your chest eventually fail. It's an incredible journey into the sheer mechanical wonder of our own bodies, where we'll be exploring wear and tear and sometimes cases of tragic biological mistaken identity. Let's kick things off with a provocative question to really anchor our journey. I want you to imagine the valves of your heart simply as doors. They exist to regulate the forward flow of life, your blood, ensuring it moves in exactly one direction at exactly the right time. But consider for a moment what goes wrong when they simply refuse to cooperate. What happens to the biological engine when its most critical doors either jam shut or break right off their hinges? To solve this medical mystery, here's our roadmap for today. First, we'll look at the mechanics of valve failure. Second, calcific aortic stenosis. Third, mitral valve prolapse. Fourth, acute rheumatic heart disease. And finally, chronic rheumatic heart disease. Section 1. The mechanics of valve failure. The stuck and broken doors.
It really boils down to two main mechanical problems. First, we have stenosis. Think of stenosis as a stiff, heavy door that's just stuck and won't fully open. This failure to open completely acts as a literal roadblock, actively obstructing the forward flow of your blood. Then we have insufficiency, which you'll often hear called regurgitation. This is a door with a totally broken latch. It fails to close completely, which means it continuously swings backward, allowing blood to reverse its flow. It's also really important to note that these can happen acutely, like if a supporting cord suddenly ruptures, or chronically due to long-term scarring. And sometimes, a single unlucky valve can suffer from both stenosis and insufficiency at the exact same time.
Now, while valve abnormalities can absolutely be congenital, meaning you're born with them, acquired stenoses of the aortic and mitral valves actually make up a massive 2/3 of all valve disease. They are absolutely the prime suspects when it comes to mechanical failures of the heart.
Moving on to Section 2, calcific aortic stenosis. Case 1, wear and tear.
It's pretty wild to think about the actual physical manifestation of this disease. Imagine these nodular, rigid, calcified masses building up right on the cusps of the valve. What you're dealing with here is the progressive, age-associated wear and tear of the valve. Typically, this process begins to truly manifest and cause noticeable problems when patients reach their 70s and 80s. However, if a patient is born with a congenitally bicuspid aortic valve, meaning it only has 2 flaps instead of the normal 3, this exact same calcification process is accelerated. In those cases, onset happens way earlier, usually when they're just 40 or 50 years old.
Because that calcified blockage forms such a rigid, stuck door, it forces the heart's left ventricle to work incredibly hard just to push blood out. It often has to generate extreme pressures exceeding an astonishing 200 millimeters of mercury just to overcome that obstruction. As a result, the left ventricle hypertrophies, or thickens. Patients unfortunately experience severe clinical features because of this immense strain. They develop angina, severe chest pain due to relative ischemia, as that thickened heart muscle literally starves for oxygen. They can also experience syncope or fainting because not enough blood makes it past that blocked door to reach the brain. And ultimately, if left unresolved, this relentless strain leads directly to congestive heart failure. Section 3. Mitral valve prolapse. Case 2. The floppy valve. While the name might sound incredibly obscure, this is actually a surprisingly common primary degeneration. In myxomatous degeneration, one or both of the mitral leaflets become loose and floppy. Believe it or not, this affects roughly 3 to 5% of the entire adult population. And here's a fascinating demographic twist. This structural issue, where the leaflets actually balloon backward into the left atrium during systole, has a massive gender disparity. It affects women 7 times more frequently than it affects men. So what does this actually mean for the patient? Well, fortunately, most people with this condition are completely asymptomatic. It's usually just an incidental finding when a doctor is doing a routine physical exam and hears a signature mid-systolic click followed by a regurgitant murmur on their stethoscope. However, about 3% of patients with this floppy valve will face serious complications. We're talking about mitral regurgitation leading to congestive heart failure, an increased risk for infective endocarditis, sudden death from ventricular arrhythmias, or even a stroke resulting from the embolism of blood clots that can form up in the left atrium. Section 4. Acute rheumatic heart disease. Case 3. The infection connection. Let's trace this remarkable and frankly tragic journey. It begins not in the heart, but surprisingly enough, usually in the throat. Rheumatic fever is an acute, immunologically mediated, multi-system inflammatory disease that typically shows up a few weeks after an episode of strep throat. Acute rheumatic heart disease is the specific cardiac manifestation of this fever, and it leads to intense, damaging inflammation across the layers of the heart. Let's break down exactly how this happens. First, the patient contracts Group A beta hemolytic streptococcus. Second, the immune system mounts a defense, producing antibodies specifically designed to attack the M proteins on the surface of those bacterial strains. But then step 3 is where the disaster hits. This is essentially a massive case of biological mistaken identity. Those host antibodies cross-react. They mistake healthy host glycoprotein antigens found in the heart, the joints, and other tissues for the bacteria itself, and they begin to attack the body's own healthy tissue. When pathologists peer under a microscope to confirm this, they look for a very specific hallmark clue, the Ushkoff body. In a heart suffering from acute rheumatic fever, they'll find these distinct clusters scattered right within the interstitial connective tissue. An Ushkoff body consists of a core of degenerating matrix surrounded by immune cells like lymphocytes and very distinct, plump, activated macrophages known as Onychkos cells. These inflammatory lesions can be found in any of the 3 layers of the heart: the pericardium, the myocardium, or the endocardium, causing a severe, widespread condition known as pancreatitis. Section 5. Chronic rheumatic heart disease. The scars of mistaken identity. Over time, the organization of all that acute inflammation results in diffuse, dense scarring that violently distorts the valve's overall architecture. Those Ushkoff bodies we just talked about, they're rarely seen anymore at this chronic stage. Instead, microscopically, we see neovascularization and diffuse fibrosis that just obliterates the normal leaflet structure. Anatomically, this translates to severely thickened leaflets, commissural fusion where the separate flaps literally scar and weld together, and the supporting strings, the chordae tendini, become thickened and fuse themselves. Pathologists vividly describe the resulting calcified, fibrous bridging across these valvular commissures as fish mouth stenoses. It perfectly captures the rigid, permanently open and stuck nature of the scarred valve. The valve can no longer open fully, nor can it close fully. It is, for all intents and purposes, a completely ruined door. And the sheer scale of this autoimmune aftermath is staggering. While the tricuspid valve is sometimes less severely involved and the pulmonic valve almost always escapes injury, the mitral valve is squarely in the crosshairs. It's involved in 70% of cases alone. In fact, chronic scarring from rheumatic heart disease is overwhelmingly the most frequent cause of mitral stenosis, responsible for a full 99% of all cases. It leads to tight stenosis, causing the left atrium to progressively dilate, which can then harbor incredibly dangerous blood clots. As we wrap up our explainer today, I want to leave you with this thought to ponder. We've explored the sheer mechanical trauma of calcification in our 80s, the genetic quirk of a floppy valve affecting 3 to 5% of us, and the tragic autoimmune scarring from a simple childhood throat infection. Given everything we now know about these profoundly broken doors, how do you think modern medicine can possibly step in to repair or entirely replace them? It's an absolute marvel of an engineering challenge for the medical world and a fantastic topic for you to explore next. Thank you so much for joining me on this deep dive. Keep learning and keep questioning the mechanics of how we work.